Okay, well, we're at the top of the hour. I think we'll get started. Welcome everyone to ASJ GEMS Global Educational Meetings. We're extremely excited to have Dr. Pat Pazmino with us and Dr. Rios with us. Dr. Pazmino graduated with honors from Harvard University with a degree in biochemical sciences, and he completed a medical school and an integrated general surgery and plastic surgery residency at Baylor College of Medicine in Houston, Texas. He then came to South Florida, where he founded Miami Aesthetic, and that's where he practices today. Dr. Pazmino's research interests include body contouring, patient safety, integrated ultrasound technology with plastic surgery, and identifying unique mango varietals, which hopefully we'll have time to get to after the lecture today. Welcome, Dr. Pazmino.
Phaedra, thank you so much. Thank you for the kind welcome. And it's truly an honor. It's an honor to participate with ASJ GEMS and to talk a little bit about our experience here in Miami. Again, my name is Pat Pazmino. I'm a board certified plastic surgeon in private practice here in Miami. Our city is really well known as a mecca for body contouring and gluteal fat grafting. But unfortunately, we are also famous as the city who has had the most deaths from these procedures. So today, I would like to go ahead and talk about the fat grafting lessons that we have also learned from the Miami morgue. I would also, after we go ahead and talk about the morbidity, I would also like to discuss how gluteal fat grafting can be performed by every surgeon every time. These are my disclosures. I design and teach plastic surgery applications with an ultrasound company. If any of you are interested in this technology, I can actually get you a discount if you just reach out to me. This is my contact info on your cell phone or browser. If you type in drp.miami, it will automatically download my business card, phone, and email. This link will be on the bottom of every slide today. So please feel free to reach out with any questions or feedback on how I can improve this talk. Please send as many critiques, as many comments as possible, because that's the only way that I can improve. Now, everybody in the world loves gluteal fat grafting because it can create very dramatic and beautiful results. But the popularity is also driven by high demand and also by equipment companies who are actually encouraging non-plastic surgeons to perform surgeries where they have no training. This is a brochure from a well-known equipment company that states that in 30 minutes, anyone, not just a plastic surgeon, but anyone can go ahead and make $2,000 if you only buy their equipment. Now here in Miami, this has really led to a race to the bottom. We have many budget clinics here in Miami that continue to discount this procedure. Here, the price started at $5,000, it went to $3,500, then it went to $2,999 for a BBL, $2,900, and then the new low ballpark winner is $2,500. So predictably, all of these factors have led to a surge in gluteal fat grafting in Miami, as well as an avalanche of deaths. The TV stations, newspapers, and other media here in Miami have closely followed the tragic, unnecessary death of one woman, Edel, Maribel, Linda, Christina, Heather, Tracy, Maria, Nikisha, Renika, Jasmine, Latia, Kizzy, Delma, Adianette, Sherry, Lisa, Dania, Raquel, and Audrey. Now, as plastic surgeons, we responded to all these deaths by first looking at the data. We wanted to analyze these deaths. So who are these people? Well, they're all not just women, they're all young mothers. They have an average age of 37 years, an average weight of 171, and the BMI an average of 28.1. Remember that these deaths are devastating, not just for the woman, but for the family. At least 24 orphans have been created because of these mortalities. Well, regardless of where they come from, we have patients from Washington, California, Louisiana, Missouri, Illinois, also internationally, where regardless of where they come from, they all have ended up in the same place. And that's the Miami-Dade County Medical Examiner. At the examiner's office, the chief medical examiner, Dr. Liu, performed all of the autopsies. And what she determined is that all of these patients died from fat pulmonary emboli. That's when fat enters a vascular tree, it travels to the heart and lungs, and it causes respiratory failure and death. Now, this is interesting. The ME determined the cause of death, but we as plastic surgeons were actually interested in the entry wound. How exactly did fat graft get into the vasculature? So the ME went ahead and got a plastic surgery consult. This was the most unique consult I've ever received. But 2 to 3 board certified plastic surgeons, we went down to the morgue, we observed the gluteal dissections by the medical examiner, and we provided assistance with gluteal anatomy, because this is an area that the medical examiner typically does not go to. Because we have now done 10 autopsies after a fat pulmonary embolism death. Because we've done so many of these, we've actually designed a novel autopsy technique that we call the gluteal butterfly. And here you can see that the skin is incised in the blue lines and the flap is maintained laterally. Once the skin is reflected, we see the gluteus maximus muscle, and then that is detached along the purple lines. And once that is reflected, we can then identify the sciatic nerve and we can travel towards the gluteal vessels. So this allows us to identify the gluteal vessels, see if there's any injury there, and then afterwards we can go ahead and see the gluteus maximus above. When we bread loaf the gluteus maximus, this is what we have found when we see a fat pulmonary embolism death. Here you can see the gluteus maximus muscle. It is not supposed to have all this fat inside it, but when we bread loaf it, we see all these channels, all these tracts full of fat graft. In our dissections, here is an example of subcutaneous fat graft. This is just sitting on top of the muscle. And when we remove it, here we can see the subcutaneous gluteal fat graft, but also the intramuscular gluteal fat graft right underneath it. That is the sine qua non of this problem. If we go ahead and elevate the gluteus maximus, we can go ahead and see our vessels. And here in this case, this is the gluteus maximus above, the gluteus minimus is below. We see the sciatic nerve here. There's no fat graft on this side. However, on the same patient, when you go to the other side, you can see loose fat graft. So this is a case where this surgeon on one side went ahead and performed fat grafting that was so deep, it actually went underneath the gluteus maximus. In this picture, the head is above, at the top, the feet are below, and the gluteus maximus are now reflecting towards the midline. And so we can see underneath that on the patient's left side, they have loose fat graft underneath gluteus maximus that is not present on the right side. We also go ahead and look closely at the vessels, and not always, but often we go ahead and find a vascular injury. This is a gluteal vein injury that we have been able to go ahead and put our trocar in. And this trocar, it shows the path of the cannula as it went and injured these vessels. Again, another example of intramuscular fat graft. You should not see this. Now, after the fat graft goes into the the vasculature, it will go ahead and go to the iliac vein and into the IVC toward the heart. Here, we have resected the IVC, and you can see all this fat graft pouring out of the inferior vena cava into the hepatic recess. The liver was taken out here. This is the diaphragm. And as it goes up into the left atrium, we can see a heart full of fat graft. This heart will then go ahead and pump this fat graft through the pulmonary arteries. We can see that there. And the fat graft, it just keeps going and going into the lung until it gets to a vessel that's too small, and then that's where it occludes that vessel. This is some fat graft close up that we have taken out of the pulmonary arteries. And when we go into the lung parenchyma itself, when we go ahead and resect some of these blood vessels, you can see fat graft just pouring out. Now, the common findings of these autopsies, all but one of these deaths had intramuscular fat graft. So that's the most important thing, intramuscular fat graft. So then that's what really highlighted the direction of what we wanted to study. So as plastic surgeons, we're scientists first. So we decided to take this finding of how to prevent intramuscular fat graft and go back to the lab. We were very blessed by the Multi-Society Task Force. This is a group of plastic surgeons headed by Dr. Rubin, Dr. D'Amico, Dr. Saltz, and Dr. Mills. And they went ahead and they created this task force. And we really want to send a big shout out for the support of ASERF. This is where some of the ASERF money went. At the task force, we went to a research facility here in Miami and we performed cadaver studies. We went ahead and collected fat graft. Now, other studies have tried to do this with somewhat similar substances like applesauce. We actually went to the community and we got real lipoaspirate. So we got real lipoaspirate and we got expert injectors to come in and do fat grafting under fluoroscopy. This allowed us, we dyed the fat graft, and when we were able to do this, we were able to track where every drop of fat graft came from, every single approach. Here is a couple examples of fat graft that we dyed green, orange, purple, green, orange, and black. When these expert injectors went ahead and did the fat grafting, we also followed their cannulas through fluoroscopy. And this is a good image of the cannula going in and disrupting the gluteal vein. And we can see this blush here as well. So once we found how to go ahead and injure the vein, we then documented, well, what approach did that cannula take? So we are able to measure the angles of the cannula, the lengths of the cannula from each of the traditional incisions. And then finally, we dissected every single cadaver to go ahead and identify the placement for each surgeon. So with all this information, in 2018, ASERF came out with 9 recommendations for gluteal fat grafting. What's interesting is out of the 9 recommendations, 6 of the recommendations have one theme, and that is basically 3-dimensional awareness. It is very, very important, according to the recommendations, to always know where the cannula tip is. So in a nutshell, the 2018 recommendations from ASERF were to, number 1, keep the cannula superficial, and number 2, to keep the cannula above the muscle and the deep gluteal fascia. Other things they recommended to help surgeons do this is use a cannula more than 4 millimeters in diameter to avoid the bending that we see in a thin cannula, to avoid a lower lock cannula interface, because that could be unstable, to preferentially use an intragluteal incision to jackknife the patient, and to only inject while the cannula was in motion. So taking all this information that we have learned, South Florida plastic surgeons, we then went and advocated on the behalf of our specialty. And we went and spoke to the Florida legislature, as well as the Florida Board of Medicine. In 2019, the Florida legislature, because you have to understand this, in this community, this has been outrageous, all of these deaths, all of these problems. The Florida legislature passed restrictions on these clinics. This is very interesting. The Florida Board of Medicine in 2019 released an emergency order mandating that all gluteal fat grafting in the state of Florida had to be above the muscle, above the gluteus maximus. This is the first state in the country to mandate exactly how a surgeon is supposed to perform a surgical procedure. Just think about that. The Florida Board of Medicine also stated that violators can lose their medical license if they violate that emergency order. So this is the dilemma that Florida surgeons found themselves in. We now know that we have to stay superficial because of the findings we found from the Miami morgue, from the advice of the plastic surgery societies and the task force, from the Florida Board of Medicine stating that if we don't, we can lose our license. So Florida surgeons are now betting their medical licenses every single time they perform gluteal fat grafting. Florida surgeons are betting their medical license that if they go under the muscle and inject fat into the muscle, they can lose their medical license. So let's take a look at the mortality rates. In 2017, ASERF performed a survey that estimated the rate of death from a fat embolism to be 1 in 3,000. This was actually very difficult to calculate, and many of these surgeries were not done by board-certified surgeons and not done in accredited facilities. This statistic has recently been drawn into question. In 2019, ASERF repeated the survey and found that after the recommendations were released in 2017, the mortality rate did fall to 1 in 14,000, which made gluteal fat grafting approximately just as safe as a tummy tuck. This rate was also confirmed by a survey of Brazilian plastic surgeons that calculated the rate to be 1 in 20,000. So this was fantastic. The survey attributed the decrease in mortality to 94% of surgeons being aware of the subcutaneous only recommendations. 85% of surgeons actually switched their technique. That's so hard to get a surgeon to do. And this was an incredible achievement. If you think about it, this could not have happened at any other time. This was a fast response. Bench research was quickly brought to the clinical setting and the OR. The ASERV quickly released new recommendations, and surgeons actually changed their techniques. So that was terrific. So is this a cause of celebration? We fixed gluteal fat grafting. That's fantastic. So why are we still talking about this? Well, unfortunately, I'm here to report that as of July 2019, here in Florida, we have had 3 more gluteal fat grafting deaths from fat pulmonary emboli since these recommendations have been released. The pandemic did stop a lot of things, but unfortunately did not stop fat pulmonary emboli. In February of 2020, a young mother in her early 30s in Tampa underwent a tummy tuck and a gluteal fat grafting. She became unable to unable to oxygenate. She entered cardiac arrest in the hospital, and where she was transferred and subsequently died. The Tampa medical examiner went ahead and performed the autopsy, and they found a fat pulmonary embolism. However, they did not dissect the deep gluteal tissues. So the family actually chose to exhume the body and requested myself and Dr. Garcia to go to Tampa and participate in a private autopsy. This is our very, very good friend, Dr. Halpern. At the time, this was the pandemic, so the highways were closed. So he was kind enough to help us by flying us out there on his plane. So thank you for that. Now, after the clinics opened again in August of 2020, there was yet another gluteal fat grafting death. And this one really hit a lot of papers. The Florida Surgeon General noted that this death was investigated, and the Florida Surgeon General concluded that Dr. X, their conduct of using an inherently dangerous and illegal fat grafting technique, despite the known risks of increased mortality, indicated that Dr. X is not capable of performing surgeries in a manner that is correct and safe, and that Dr. X is prohibited from performing any procedures involving fat transfer or fat grafting. So this is very, very much in our mindset and in the news here in Florida. So if you looked at the statistics as of May 2020, we did have 18 deaths, but now currently our total stand is 20 deaths in the last 10 years, 6 deaths in the last year, and 2 deaths in August of 2020 alone. Please remember that the deaths in August of 2020, they were both from board certified plastic surgeons. So we have to address this because this is happening. This is happening here. It's currently happening to our colleagues, and it's currently an issue. Now, this is the this is the least favorite part of when I talk about this, because I actually have to update these statistics. Here in Miami, we have now had 2 more fat pulmonary emboli in the last 2 months. The first one was in March, and the second was in April. In March, a 26-year-old female went to a budget clinic. She became hypoxic down to 70%. She presented to with a fat pulmonary embolism and a left arm hemiplegia. And it looked like she had a stroke. They went ahead and performed an echo, and she actually had a patent foraminal valley. So she had fat graft go into her heart, go through the foraminal valley, and then go up to her brain. She received a septal occluder by an interventional cardiology, and because of the significant edema, neurosurgery became involved, and they performed a right hemicranectomy. Think about that. She's 26 years old. She went in for a BBL. In April of 2021, another young woman went to a budget clinic. Afterwards, she developed post-op hypoxia. She went to where they identified a fat pulmonary embolism. She was not able to keep her oxygen levels high enough, and she's currently on ECMO. So think about it. This is affecting our patients. These are young women, and this is still an issue that keeps happening. We must keep this in mind. This is still going on. So we now have to look at this as an opportunity to review the history of our investigations, what we learned from the autopsies and cadaver research, and we have to find a way to make gluteal fat grafting safer. So let's take a closer look at these deaths. Again, the common findings were that almost every death had intramuscular fat. Who were these surgeons? 11 were not board certified, but 8 were board certified. These surgeons use a variety of techniques, every incision, every different cannula type, and every injection system, syringe and microwave with the EVL. Now, this is a really important slide. In 2018, the ASRF recommendations asked the surgeons to change their techniques. Now, what's interesting is that if you look at the documented deaths from the ASRF, we have documented deaths that actually followed the ASRF recommendations. We have 3 deaths so far where surgeons use cannulas of 4 millimeters or greater. We have 3 deaths of surgeons that use a non-luer lock system. We have 2 deaths when surgeons use a sacral incision. We have 1 death in the jackknife position, and we have 3 deaths with the expansion vibration lipofilling. So the task force recommendations are not enough. The one thing that all of these deaths had in common was that every surgeon documented that they only injected subcutaneously. Every surgeon thought they were subcutaneous, but unfortunately, the autopsies disagreed. So what the Miami Morgue has taught us is that cannula tip awareness by palpation is simply not enough. I would argue that we are focusing on the wrong side of the incision because gluteal fat grafting will always remain dangerous as long as it's a blind procedure. The location of the tip of the cannula is much more important than the type of the cannula, the incision, or any other factor. Our main focus should be on confirming the tip of the cannula at all times. And palpation, again, is simply not enough. So we have to remember the lessons of the Miami Morgue to stay alert, remember who these patients are. They're all young mothers that we're treating. To stay humble, to really understand where we are, and to know that there's no fail-safe cannula, incision, technique. The deaths have been happening to very experienced surgeons. The deaths have been happening to board certified surgeons, and we just simply cannot rely on palpation because palpation plus a lot of experience, it still makes it a blind procedure. And to call a BBL safe and subcutaneous does not make it so. The BBL does not need to be rebranded. The BBL needs to be reconsidered on how we are staying subcutaneous. So there is a solution for this. So plastic surgeons love new technology, and there is new technology that can help us confirm the cannula tip placement. There's been amazing work that has come out of the University of Pittsburgh with a smart cannula that uses impedance to identify whether the cannula is in the fat or the muscle. We can also visualize the cannula tip with real-time intraoperative ultrasound. So this is what we can do now. We can go from awareness, that's what palpation is, to tip confirmation. That's what visual confirmation is. This technology can also help us document where every drop of fat goes. It can help us become safer surgeons and better surgeons. So to talk about ultrasound physics in under a minute. This is the range of sound waves. These are mechanical waves. And the interesting part here is the ultrasound range is more than 20 kilohertz. When you look at this, other specialties have gone ahead and used lower frequencies for deeper structures. As plastic surgeons, we're more interested in superficial structures. So this is the range that we're interested in, between 11 and 20 megahertz. So one key point with this technology, the higher the megahertz, the better the resolution, but the less deep you can actually see. So that's important. So surgeons, plastic surgeons, what we do, because we're working with superficial structures, 11 to 20, that's the sweet spot. Now, ultrasound used to be based on, well, it's based on the piezoelectric effect. They used to use quartz crystals to go ahead and run a current through the quartz crystal and create an ultrasound wave. This was delicate, and this actually made these instruments very, very expensive. The ultrasound transducer, it acts both as a speaker and a microphone. It bounces a wave out and it listens to it coming back. When you look at ultrasound, the property of the tissue is echogenicity. This is the important part. Dense stuff looks white. Less dense stuff looks dark or black. So really dense stuff like bone, instruments, cannulas, metal, all that stuff looks white. Less dense stuff like water, fat, that will look black. There's a lot of different ways to go ahead and set the ultrasound a lot of different settings. But I think the really interesting thing is that here in the 21st century, ultrasound now uses artificial intelligence and software, so it's very easy to use. This is really important that we'll touch on. These are actually sonographic tape measures. We can go ahead and measure linear measurements and area and volume. We can also take photo and video, and we can also use other modes to look at blood vessels. So there are just so many options. What about what's going on now in 2021? Well, this is the exciting thing, that in the 21st century, we do not need crystals anymore. Computer chips can now produce this effect. This makes them cheaper, flexible, and we can control these with software. So this is amazing. Before, centers used to need a lot of different probes to go ahead and create different ultrasound patterns. Here, we can use one probe and software to change the pattern that's coming out of there. So this is fantastic because this puts it all into our pocket. These chips are getting smaller and smaller. This is an example of a chip that that they've shrunk and put on a Band-Aid. And they're thinking about incorporating this into clothing, into gloves. Imagine wearing a T-shirt that will communicate with your cardiologist when you're having an arrhythmia. They have even shrunk ultrasound probes to the size smaller than a red blood cell. And this can actually detect the activation of specific genes. So it's really fantastic how there's just so many new advances with ultrasound, but plastic surgeons have to get involved. So this is the question that I get asked most commonly: which ultrasound do plastic surgeons need? Well, with my 8-year experience in ultrasound, I've worked with 6 different systems, and they're getting better and better, and more importantly, easier to use. So in a nutshell, for plastic surgeons, we need a linear probe, high frequency, 11 to 20, portable is wonderful, and waterproof helps. Here are the current systems that are out there: the Butterfly system, the Clarius, and the PS imaging. In a nutshell, the Butterfly is a medium resolution system, and these other 2 are high resolution systems. Well, one of the systems that I'll talk about that I frequently use, this is a Clarius. It's small. This is the size of my iPhone. It's a linear probe, high frequency, uses artificial intelligence, and the best part is that it has its own Wi-Fi hotspot. That means that this can work with an iPhone or an Android. So let's go ahead and see this in the OR. So here I am. The nurse just handed me the probe, and I'm putting it into the probe cover. I'm going to go ahead and tie a knot and sterilize it. My probe is now completely sterile, and it is ready to go. Because it's a Wi-Fi hotspot, it's actually going to communicate right here to my tablet. So what I like to do, I also like to bring in a mouse on the field so I can go ahead and manipulate my tablet. And you can see that here, that the tablet just lit up. I just go ahead and cut that, and I am ready to go. My ultrasound probe is ready, no cords, no cables, I'm ready to go. The great thing about ultrasound, there's no disposable, unlike all the other junk that they try to sell us. The only thing that this costs is the cost of the probe cover. That's $5 per case. So you can keep your patient safe for $5 per case. I think that's something that all of us can afford. So I would say let the ultrasound do the hard work. The artificial intelligence and the software, it'll adjust all the settings for you. This is why I've been working with these companies, is because we have created plastic surgery modes so that they're predefined settings. You just click it, you're ready to go with all the settings you want. Now, ultrasound, it's analogous to when anesthesia uses the glide scope. Anesthesia uses the glide scope to visualize the tip of the endotracheal tube. The glide scope provides confirmation that the ET tube was accurately placed the first time in every single patient. Every other specialty confirms their work with visualization. Orthopedics, they use x-rays to confirm a fracture reduction. Cardiology uses x-rays to do coronary patency. GI uses endoscopy to go ahead and look at the health of the intestines. Even ER doctors use ultrasound, and they can't even close a forehead lag. So there's no reason why plastic surgeons can't use this. So this is one of the really crucial things about ultrasound, that for the first time, it allows us to see subcutaneous anatomy that we have never been able to appreciate. For example, there are in fact 2 gluteal fascia, the superficial gluteal fascia and the deep gluteal fascia. And what ASRF has recommended is to never inject below the deep gluteal fascia. So here's an example of how ultrasound can make any fat grafting technique safe. So this is interesting because everyone has different preferences. I'm going to go ahead and use ultrasound on 4 different techniques. Here I'm using a 2mm luer lock. Okay, remember, ASRF recommended more than 4 millimeters. They recommended not the luer lock. But what if the surgeon really feels very comfortable with this? Ultrasound can make it safe. Look at this. Here, this red line, this is the deep gluteal fascia. I have visual confirmation. This bright white line is my probe right there. I know for a fact that I'm above the deep gluteal fascia, and I can go ahead and inject with my favorite technique. This one is a 3.4mm Toomey. It's on a Toomey hub with a big syringe. If a surgeon wants to go ahead and do this, I can go ahead and confirm that I'm always in the right place. So there's no magic cannula, there's no magic incision. It's all about where your placement is every single time, every single pass. Here, my probe is the only thing that's moving in this picture. It's the big white thing. I can see that up here. This red dotted line is a deep gluteal fascia. I'm way above it. I can go ahead and fat graft very well. Take a look at these dots here. Remember, the ultrasound is a ruler. I'm going to point this out in a moment. Here's a 3.7mm spoon tip, and we're going to go through the supragluteal fascia, supragluteal incision. Remember these little white dots. These dots is our ruler. This is 1 centimeter below the skin. This is 2 centimeters below the skin. Here is my cannula. There's my deep gluteal fascia. Just think about it. I'm working about 2.5 centimeters below the skin. That's an inch. That is the thickness of the space that we're working on. It is a 1-inch dome. There's not a lot of room for error. This is my favorite technique described by Dr. Del Vecchio. This is the EVL with the micro air. I really love this technique for the simplicity and the efficiency. And it allows me to go ahead and completely free up one hand while I do this. I just prime my line. I'm going to put my probe into the supragluteal incision. And in my first pass, look at this. Here's a deep gluteal fascia. My probe is inside the muscle. My probe, look at that. I'm displacing the striated fibers of the muscle. My probe is inside the muscle, and I would not have known that if it was not for ultrasound. Ultrasound kept me safe. I just used that same incision for 3 different techniques. And when I put in my favorite one, I was under the muscle. Ultrasound identified that. I was able to realize that and then reposition. Now that I'm above the muscle, I can fat graft safely. So ultrasound keeps me safe all the time. And that's really what makes this procedure in my hands so humbling, because so many times, even though we try our best, we really don't know where we are. Ultrasound can be used on any patient, even thin patients. It can be used in any position with any cannula, with any incision, with any fat injection system. It adds no additional OR time. When I do fat grafting, it literally takes me between 5 and 10 minutes per side with ultrasound. And the only thing that ultrasound adds is $5 per case for the sterile probe cover. Ultrasound can be used by any surgeon. Ultrasound can help us make this technique safer. It can help us create reproducible results. And more importantly, it can help us teach this technique. We can go ahead and see where we are, and with confidence, we can show our residents where to inject fat safely. Ultrasound takes the guessing out of the equation. And that's why ultrasound with gluteal fat grafting can make it ultra safe. Now, when I talk about this, I often hear, well, if I can't visualize where my fat grafting tip is at all times, what is the worst that could happen? I have also heard if a surgeon can do tumescence and lipo safely, they can fat graft the butt safely. There's no need to use ultrasound. Well, unfortunately, we have 20 cases in the Miami morgue that would disagree. Those 20 cases were not there because of liposuction complications. They were not there because of tumescent complications. They were there because of fat grafting that was done inappropriately. And then finally, a few weeks ago at the gluteal panel, I heard this. If you can feel and see your cannula tip poking through the skin, you're always subcutaneous and safe. So I wanted to investigate that. So here's an example. I'm using the EVL system, my favorite system, designed by Dr. Del Vecchio. I'm going through the intergluteal incision. That's what the ASRF recommendations recommend. This is not a luer lock. This is a rigid system. It's a large, about a 4mm cannula. And I am poking through the skin because I want to go ahead and fill these hip dips. So I am superficial, supposedly, at all times. So what I've done here, this cannula is in position. I'm not going to move the cannula, and I'm going to trace the course of the cannula from the incision out to the skin. So let's take a look. This white line is my cannula. The green line is the deep gluteal fascia. Look at that. I'm already underneath the deep gluteal fascia. We can see striated fibers above. My cannula is already in the muscle. As I go ahead and I walk down the cannula, I'm walking down, I'm getting deeper and deeper into the muscle. The cannula is still in the muscle. I like the bent cannulas recommended by Dr. Del Vecchio and Dr. Wall. And so now you can see, there it is. That's the bend of my cannula. It's starting to go up. So here it comes up. This is my cannula. I'm not moving at all. I'm just tracing it with my ultrasound. Now it finally went above the deep gluteal fascia and it comes up and there we go. It is poking through the skin right there. It's poking right underneath the dermis. So even though we can see on the outside that it is poking through the skin, the shaft of the cannula can still be where we don't want it to be. So one of my favorite papers was this one in PRS from 2019, where Dr. Del Vecchio, he really stressed the importance of an intact deep gluteal fascia. They call the deep gluteal fascia a stout wall, because if it's intact, it can keep fat graft compartmentalized, which is absolutely true. Here in this picture in the upper left, the deep gluteal fascia is intact, so all the fat injected subcutaneous stays subcutaneous. If the deep gluteal fascia is intact and people inject underneath the deep gluteal fascia, it'll keep it all on the inside. But this is what's really interesting. Dr. Del Vecchio noted that the more perforations of the deep gluteal fascia, the more the subcutaneous fat graft will migrate into the muscle. So if you have a lot of perforations and a lot of passages through the muscle, even though you're injecting fat subcutaneous, this can go through the muscle and it can go and hurt the gluteal vessels. So what that video showed is that ultrasound is the best way to follow Dr. Del Vecchio's advice, because palpation alone can lead a false sense of security. Palpation alone can lead to inadvertent perforations of the deep gluteal fascia and the gluteus maximus. That can also create channels within the gluteus maximus for fat graft to migrate through and to get deep intramuscular migration. If we visualize where our tip of the cannula is at all times, if we stay away from the deep gluteal fascia, we can maintain this deep gluteal fascia as the stout wall and keep all our fat grafting above. So this last part of the talk, I just want to talk about what ultrasound can do for the safe surgeons. It can actually make us more precise. So this part of the talk is for surgeons who are very experienced. This is a tool that we can use. It can actually allow us to see and manipulate the subcutaneous anatomy. We can target and release specific fibers, and we can target and fill specific spaces. Again, these are the two fascia of the butt. What's very interesting is that the superficial gluteal fascia will divide the subcutaneous region into two spaces, the superficial subcutaneous space and the deep subcutaneous space. What ultrasound allows us to do is targeted fat grafting. For the first time, we can go ahead and only put fat in one space or the other. That is not possible with palpation. So let's go to the OR and take a look at some targeted fat grafting. So the first one that we'll go ahead and see is targeting the deep subcutaneous space. I'm going to go from the supragluteal incision, and I want to get great dome projection. Here is my dermis. Here's the superficial gluteal fascia. Here is the deep gluteal fascia. There's the gluteus maximus muscle. There's a superficial subcutaneous space and the deep subcutaneous space. I want to target this. And look at that. Right here, this is the superficial gluteal fascia. I haven't violated that. That's totally intact. I am using it very similar to the way Dr. Del Vecchio described, as a stout wall. It's like the casing of a sausage because it can hold the fat underneath. I'm literally creating a subfascial implant to give me great dome projection. Here's another example, super clear. This is my superficial gluteal fascia. There's my cannula right here. And look at that space expand. Beautiful. I can get some great dome projection. So I can do that very, very deep. I'm not going anywhere near the dermis. So I'm not going to get blowout injuries. I'm not going to go ahead and get deformities. This is a very, very precise way of doing this. And look at this, 1 centimeter, 2 centimeters. I'm doing all this within an inch of space. So ultrasound gluteal fat grafting can make this procedure ultra precise and get ultra perky results. Other benefits, we can see subcutaneous structures, so we can see them, now we can manipulate them. We can also go ahead and use this before and after surgery to plan and measure how much fat we're going to use and also to do body mapping. In my patients beforehand, I go ahead and do ultrasound maps of each area and I identify what's thin, what's thick, and it helps me plan where I'm going to go ahead and do my fat grafting. Here, and this is another example of an ultrasound body map that I create. I can determine exactly where I'm going to put the superficial fat and the deep fat. And this allows me to get the results that I want. So it allows me to communicate with my patients. This is an incredible new tool for plastic surgeons. As plastic surgeons, it allows us to preserve and respect subcutaneous anatomy, to plan surgical procedures, to target and release specific fibers, and target and precisely fill specific spaces. That's not possible with palpation. Ultrasound with gluteal fat grafting, it's the tip of the iceberg in plastic surgery. We can also use this, of course, with breast fat grafting. We can do breast implant assessment, which is incredibly useful. We can use this to manage seromas, tap blocks, facial applications, and so much more. The legacy of plastic surgeons is that we embrace new technology. We always have, to better understand our anatomy, use our imaginations, and combine these two to invent new procedures that will help protect our patients and move our specialty forward. So my call to action today is try it. It's very cheap. These units can cost anywhere from $2,000 up to $15,000. There's no disposables, just $5 for the cover, and it can be used in the OR and the clinic. If you're interested, ask for an ultrasound course and consider inviting me back. I want to thank Dr. Rios and ASRF and Dr. Nahai for this kind invitation and allowing you to share our experience. Thank you.
Thank you so much, Dr. Pazmino. You've given us so much to think about. It's a great presentation. Everything from the cost and the potential for, the cosmetic tourism and, kind of being sure where the procedure is done is critically important. The research that has been published not only in ASJ, but elsewhere as well. And I think most importantly, that this is a safety issue and it is being improved through research and science and the investigation that you and other colleagues have done as well. So I think I wanted to focus on one of your points, which is that there's a 3D awareness and to know where the tip of your cannula is at all times. I think that was a very important pearl and takeaway for me as well. And in addition to that, the ultrasound and the possibilities that you mentioned, which I know Dr. Rios wants to go ahead and get into once he is starting to discuss with us. I had one question before we introduce Dr. Rios, and I wanted to also give Dr. Nahai an opportunity to comment on your presentation. When you are using the ultrasound machine, are you recording all of the procedure for, kind of, I hate to say it, but malpractice potential issues later down the road? Is that one of the advantages of the ultrasound?
Absolutely, thank you. That's a great question. And yes, I do record these procedures and it allows me to prove that I was exactly where I thought I was. And it allows me to document this. We can put this in the patient chart as well.
Excellent. Okay, that's what I was hoping the answer would be. Dr. Nahai, I know you're with us. I'm going to unmute you. I'd love to see if you had any comments before we move on to Dr. Rios.
Absolutely. Thank you so much. This has been one of the most informative and, dare I say, sobering gems that we have had. Your incredibly clear presentation of discussing the problem, how you and your innovative colleagues looked at the problem, came up with a solution. The two questions I had, one was to tell you, you really impressed me with that shot where you had the cannula under the skin, but you had already gone through the muscle to get there. And I think that's a lesson for all of us and a lesson that can easily be translated to liposuction and the intra-abdominal injuries that are seen from time to time. The only question I have is to ask you, is the learning curve as easy as you made it look? Are we all going to be able to see those layers as you clearly pointed out?
Thank you, Dr. I truly appreciate it, and thank you for the kind words and the support. The learning curve, it's really not that bad. I really call ultrasound, this is the stethoscope of the 21st century. And we all had to learn how to use a stethoscope in medical school. The way that we did it, we use it on ourselves, on our girlfriends, on our family, on our pets. And that is literally what I did with ultrasound. That once I got it, I started scanning myself, my abdomen, my arms, my wife, her breast, everything. And every patient that came in the door, you just go ahead and you can put ultrasound on there. There's no radiation, there's no cost. It's just like a stethoscope to go ahead and do that. The more that you do this, of course, the better eyes you'll get. So, and then you also can develop little tricks to get a really nice image like we showed. But it's not that steep. And what I love about it is rekindled, as a plastic surgeon, it rekindles your love in anatomy, because you get to see all the anatomy that we know and that we truly appreciate.
Well, that's wonderful. We appreciate it, and thank you for the comments, Dr. Nahai. I'd like to now introduce Dr. Rios, who is our discussant. Dr. Luis Rios Jr. is a board-certified plastic surgeon, certified by the ABPS. He's active in plastic surgery research and has presented at national meetings of both the Aesthetic Society and ASPS. He is the immediate past president of ASERF, who is the exclusive sponsor of our ASJ GEMS today. And he graduated valedictorian from his high school, received an undergraduate schooling in biology at Harvard University, and earned his MD at Southwestern Medical School in Dallas, Texas. Dr. Rios then went on to complete a successful residency at UC Davis, and then moved up from resident plastic surgeon to chief resident plastic surgeon at Tulane University. Dr. Rios, welcome. We're excited to have you here to debrief and untangle some of the more complex issues that Dr. Pazmino has just presented to us. So welcome, and I'll hand over to you for discussion.
Thanks, Phaedra, and thanks, Fuad, too. You know, this is a great forum, and ASERF is very happy to participate in this. And I think this is, you know, this is money very well spent. When I was a junior board member on ASERF, the first task force paper came out, and I was somewhat impressed because, you know, at our research foundation, the officers weren't doing very much for a few years. And then, you know, that paper came out, and I was like, wow, you know, finally the research foundation tackled an issue and was active, proactive, came up with some recommendations. But then like a few years later, I thought, well, let's kind of study that and see what happened. Did we improve the techniques, which was the follow-up paper and also came from the research foundation. What's exciting is for me to see that, okay, we landed there, but now we're actually taking it to a new level with what Pat is discussing today, you know, because, you know, we came up with the recommendations, we found out maybe it got safer, but hey, let's even take it to, you know, another level. And so it's really exciting to see that this is going in that direction. And because of what we've seen, you know, it's serious what Pat has seen in the last few months. You know, people are still dying, you know, from this procedure. And so I'm glad. I mean, that was such a clear presentation, Pat, and you really made a good argument, you know, for using ultrasound and incorporating that into this procedure. And so, you know, I've heard discussions on the podium with it, and you've heard it too, right? You've had to argue your case. And I think you make a great argument in what you're doing. And we talked about this yesterday. I think market forces are eventually going to push this forward, you know, in using ultrasound and for this procedure. So I kind of had a few questions regarding the ultrasound. All the ultrasounds that you showed me, is Clarius the only one that you can get in? Because I had a butterfly, but that you have to connect to your iPhone. I don't know how you could actually make that sterile. Maybe you could if you put your iPhone in the bag. Is this the one? Is this the easiest one to put in a sterile bag and use during surgery, would you say, or are there any other systems?
Thank you. And you're absolutely right. I mean, if you, I like it because it's wireless and you can put it in the bag very easily. I have used the butterfly. Um, it just depends on the bag that you use. Clarius does have a portable one. There are some other ones, some generic ones from Korea as well, but they don't have the software. And that's what I really like about this system is that they're very, very responsive to plastic surgeons. They have been very open about working with us and really helping us with, designing our own settings. So it just makes it very easy to use. One thing that I like about
I've seen courses at ASPS and the society talking about the Clarius with breast ultrasound and kind of, so getting into that and kind of two questions. One from Fuad was, how many cases do you think it would take for someone to get facile? And then do you anticipate teaching the techniques, anticipating teaching the techniques at the meeting?
Absolutely. Honestly, I think it would probably take about 4 to 5 cases to go ahead and get this. But I think that's with preparation. I think what really helps is use the ultrasound before on a patient or on a staff member or a family member to go ahead and look at the anatomy, become very familiar with it. And once you become familiar with the anatomy, then when you put a cannula in the middle of it, it becomes very easy. It becomes very obvious to see where you are.
Have you had any issues with the Bluetooth connection? Because I hear little rumors about that, oh, don't get the Clarius because there could be some sort of issue with, I didn't realize it had its own Wi-Fi hotspot. I thought it had to go through your server. So then there's this thing, what if your server goes out? What if, you're on generator or something, so it actually just connects with its own little, have you had any issues with the Bluetooth connection?
So the Clarius, it does not use Bluetooth. It only uses Wi-Fi.
Okay. It only uses Wi-Fi.
What's great is that it's a Wi-Fi hotspot, so it can actually transmit the image to 4 or 5 different tablets at a time. So sometimes when I teach this, each person can have their own tablet and they can see everything that's going on.
Okay. Another interesting thing, you were talking about looking at the different planes and then talking, mapping out things. We all run into patients who have cellulite or have depressions that we're trying to, raise up. And I got a little pickle fork thing that I can get in there and try to release the bands. Have you been able to visualize those depressions, and has it helped you, get a little bit better at that? Or
Absolutely. That's exactly what I have a different talk where I go ahead and I show exactly that a lot of those depressions, I mean, you do have fibers that are pulling it down. You can see those fibers, you can expand that space, you can release it, and then you can fill that area with fat. And I think that this is an exciting way to possibly treat, severe cellulite.
yeah, because now Quo has come into the mix, right? So now one aspect of that Quo injection, which actually digests those fibers, is to think about injecting beforehand, waiting a few weeks, and then doing your surgery. But if you have this, you don't really need that. I don't know. I mean, it might be an interesting study, right?
Absolutely.
But
It's a great idea.
let me ask you also now with the Clarius, and you said it had that medium frequency range. Is that also good for looking at breasts and trying to look at breast implant ruptures?
Yes, it is. And so Clarius has a low, medium, and extra high. And so the low and medium are great for what plastic surgeons use. So the low is up to 7 and the medium is up to 15.
Okay.
They have a high one that's up to 20, and that's really great for facial applications. We do that with injectables.
What about for DVTs, looking at vessels? Can the system also do that?
Yes, it can.
Okay. Well, now getting back to, let's talk about these cases that have been occurring. And you've talked that, there are board certified plastic surgeons. I think it's a good point. And I think that whole issue, what you're talking about, of us not being complacent just because we brought out these papers and the Brazilian paper that showed maybe this is still, we don't want to let our guard down, right? So you have pointed out that there were board certified plastic surgeons, but most of them weren't they mostly in these chop shops,
Right.
so-called chop shop, and maybe we don't even know if they were the ones that were putting in the fat.
That's correct. Out of the 20 deaths, 16 happened in these budget clinics. And these budget clinics, they're factories. And we've heard a lot of reports that many times the operating surgeon is not the one performing the injection. And in the morgue, we've actually seen patients where one side was grafted in a completely different technique than the other side. And that can suggest that there were two different injectors at that time.
And so are you anticipating that Florida might come down with even tougher sanctions or maybe a ban? Because Oni Garcia was very concerned because like what you said is you were able to go to the Florida Medical Board and say, look, we found the answer. If we just do it this way, it's going to be safe. And then boom, you still had problems.
Right.
Are you thinking there could possibly be a ban of this procedure in Florida like they did in the UK?
Yeah, I certainly hope not, because I mean, I think that the procedure, it can be reproducible, it can be done safely, and we can do it. When the Board of Medicine mandated subcutaneous only injection, that was really a compromise because they had so much pressure because of all these deaths. They were considering banning the procedure, and it was the incredible work of Dr. Garcia that he really pointed out all the work that ASRF supported to suggest that all the fat grafting be done subcutaneous. But when it comes to patient safety, no one is better than a board certified plastic surgeon. And this is a crisis, but it's also an opportunity. It's an opportunity that we have to go ahead, take the mantle and say, look, we're the ones who are really serious about doing this safely. And that's why patients should select us.
Yeah, I think that we do need to take the lead on this and that. Now, one thing that concerned me, about a year ago or so, and even locally here, I'm hearing is that some of the programs, when the original ASRF paper came out, and it was we almost felt like, oh my God, what's going on with this procedure? Is it just a dangerous procedure? Is there any way we can fix it? A lot of programs kind of stopped teaching the procedure. Therefore, it's going to make the procedure even more dangerous as residents come out that don't know how to do it and maybe don't know this information. Is that something you've heard too, or in how's you deal with the University of Miami? How are I'm sure they're probably very sensitive with what's going on down there. What are you hearing from residency programs, and what's your opinion about that?
It's a very big concern, absolutely. And the University of Miami, I mean, they really are a referral center for so many of these deaths. And, I am working with them to go ahead and deeply, analyze this more deeply. I think that this is a technology that it's not just for gluteal fat grafting. I mean, here there's a clear patient safety component, but I think this can help us confirm where we are. It can help us confirm that we are following the ASRF guidelines at all times. And I think that residency programs, they shouldn't seek ultrasound just for gluteal fat grafting, but for so many other applications, for breast implant, for breast, for seromas, for trauma. I do every single tummy tuck with my ultrasound because I put in the tap block at the end. And it allows us to go ahead and make the experience safer and more comfortable for our patients.
Yeah, that's a good point. So yeah, I think that as our society, and leader in aesthetic surgery, we probably need to reach out to programs and provide, this information. But do you anticipate that this could possibly be a course at the meetings?
That would be terrific. I think that'd be really exciting. And I think that this is a tool that, if you think about all the junk that people try to sell plastic surgeons, 100,000 here, 200,000 there. This is a $4,000 device with no disposable, with no additional fees. You can use it sterile. You can use it in the clinic. You can use it everywhere. And I think that once plastic surgeons start playing around with it, I'm really excited to see all the applications that they're going to think of too.
Yeah, I think eventually ultrasounds are really going to penetrate our practices. And as I talked to you yesterday, there'll be some market forces that are going to pressure because I don't know if you're advertising that you're doing the procedure with ultrasound so you can do it safer. And that's, I mean, as much as what some people might think about advertising, but when you advertise that you can be safer, you know, that you're a board certified plastic surgeon, that you can do this safer, you know, that's a good form of advertising. So I think more of that gets out, probably there will be more pressure for plastic surgeons to utilize this. But I am seeing a very positive trend. It might be, you know, um, another way to study or look at this, but I really like, you know, how you're taking, you know, now we're kind of in the third generation of the research on the BBL. Let me ask you this. I was on a panel with composite buttock grafting with the implant, you know, for people who are slender, don't have that much fat. So like Doug Steinbreck and some of the experienced guys are putting in implants and then fat around the implants. I would imagine this would also be a good tool to keep you out of the space where the implants are.
Absolutely, absolutely, and that's exactly right, because especially in those patients, their tissue is so thin, there's just not a margin of error. This allows you to put it exactly where you want. Yeah.
Yeah. So you know, Phaedra, I think this has been a great discussion, and I mean, this was a great presentation, and I'm
It
glad
was
that
fantastic.
you're
Yeah.
documenting this because, and I'm so happy ASERF participated and Dr. Nahai allowed us to do this on your forum. It really, Pat, thanks so much for bringing this up, because I think this is going to take us to the next level. We need to start putting this into our BBL panels at the meeting, because I haven't really seen this, you know, too much. So we need to really start emphasizing this, because I think it's something that's important.
I couldn't agree more, Dr. Rios and Dr. Pazmino. If you have just a few more minutes, we do have some questions from the chat box. Fantastic. From Steve Teitelbaum, he's asking, given the number of documented deaths in the past year, what do you think the actual death rate is in South Florida?
Wow, that's a that's a very important question, and then that's what we're trying to identify, because you know, the way that we're looking at this, we have been able to identify the numerator of the equation, how many actual real deaths, what the body count is. The difficult thing is to calculate the denominator, how many BBLs are actually being performed here. But that's something that we're investigating, and once we look closely, we already have a handle on Dade. We are now branching into Broward, Monroe, and Palm Beach, and working with those morgues as well. And we would like to go ahead and take this effort nationally to find out the true death rate. So
and I think, yeah, sorry, go ahead, Dr. Rios.
You know, and I think it's an important point, but I think also, you know, these deaths have all been underneath the muscle, right? So it's an important point. If we keep going underneath the muscle, we're going to see these high death rates, right? And so that's why that first paper in Dr. Teitelbaum was so instrumental in bringing that out. I mean, I admired him so much for doing that as ASERF president at that time. You know, so again, yes, if we keep staying underneath the muscle, that was the whole point, but we really haven't seen a death above the muscle. So utilizing this technology and really being conscious and aware, you know, it should be a, you know, somewhat safe procedure, you know, and taking this technique should make it safer. But if we continue to go under the muscle, we're going to continue to have these problems.
Exactly. And we have another question from Dr. Michal Klimov, and he's complimenting the presentation, which several people have done in the chat box. And he's asking, how much longer will the case be with the use of ultrasound? And he comments that you don't seem to use ultrasound gel. Does that affect the image?
Thank you. And it adds no extra time. So when I do a one hemi buttock, it takes me about 5 to 10 minutes per side. And that's simply, I'm grafting like I normally do, and I'm just following my cannula with the ultrasound. It just takes a little bit of hand-eye coordination, honestly, just a little bit of practice. And once you get it, it adds no extra time. I do use ultrasound gel. You always have to have there. It may not have been visible on the image.
On the outside of the bag, or you put some on the inside as well?
Both, inside and outside. Yeah.
I also noticed when you were when you were holding your Clarius, were you also kind of putting your pinky finger and all that to feel also the tip of the cannula? It looked like you were maybe part of your hand was holding the Clarius, but the other part was also feel right. So you probably developed that technique where you can move pretty quickly and you still because I guess maybe that would be one argument, is that if you're just holding the ultrasound, that hand isn't able to feel the can, although you're seeing it, but I
Right.
think it's even extra protection, or you feel more comfortable if you can actually feel the tip of the cannula as well.
That's
You know,
exactly right.
so
Yes.
yeah, so it did look like you were able to do both. You had developed a technique where you could do both. Yeah.
And on that point, we just got a question in the chat box from Dr. Joshua Jacobson, who's asking you to clarify which of the Clarius models that you're using, since there are several out there.
If you're just doing a body, the general one is the L7. That's great for just about everything. If you don't do any breast and body and do mostly face, you could do the L15 or the L20.
Okay, thank you very much. And the final comment I'd like to make is to share the results of our poll. We had asked before 2017, when you were performing BBL, did you fat graft sub-Q or intramuscular? 43% said sub-Q only, 7% said intramuscular only, and 50% said both sub-Q and intramuscular. And when we asked the second question, after that, it was 100%. So do you find this surprising? Do you find this, is this hopeful? Does this inspire you that people are paying attention and listening? What's your response?
What I would say is that, number one, I think that shows the incredible efforts of ASRF, that they were able to go ahead and get out the information, and now everybody is aware of this and everybody is injecting subcutaneously. However, I think, if you look at the third poll question, I think this really shows the hunger of plastic surgeons for more training and education, because now what the poll shows that, number one, 100% of surgeons are injecting subcutaneous. 86% of those surgeons are not confident where their cannula tip is at all times.
Yeah,
exactly.
Doing this procedure, they are not confident where their cannula tip is. So there's an opportunity to, let's work together. Let's make ourselves feel very confident and comfortable with this popular procedure.
And you asked the question, would you bet your medical license? 2% said yes. 86% said no. I'm wondering, does this relate to maybe the hubris that you talked about in your presentation, which is you think you're not, but you actually are?
Absolutely. And that's why I said, once you start using this technology, it really humbles you, because I've been doing BBLs for about 16 years, and I use ultrasound, I do autopsies, all this stuff, and I still get in the muscle. And the only way I know that is that ultrasound shows me, it corrects me. It does not let me fat graft into the muscle. It tells me when in the muscle, it gives me an opportunity to correct it before I do something dangerous.
Well, thank you very, very much. I'd like to give the final word to Dr. Nahai, who's still with us here. I know he wants to offer his thanks. And Dr. Nahai, over to you.
As always, the editor gets the final word. Another thank you to Pat. Incredible work you've done, incredible contribution, but equally to Dr. Rios, to Dr. Teitelbaum, and to all of the ASRF leadership that had the foresight to look at these deaths and to go ahead and come through with that paper that was published in 2017 that really led the way to making this a safer, dare I say, safe and repeatable procedure. And thank you, Dr. Rios, for your excellent discussion and your leadership in ASRF and the paper that you published, actually showing that all the efforts were worth it. It is safer. And I think with the work of Dr. Pazmino, we're going to make it even safer. So thank you both very much.
Thank you so much. Have a great rest of your day. We are very appreciative of everyone who joined us for GEMS. As a reminder, this is being recorded and we will make it available on the ASJ website as well as Radar Resource. So thank you so much, gentlemen, and we will look forward to your future work and research. Thank you so much.
Thanks, Phaedra. Thanks, Fuad.
Take care.